Introduction to Nursing Concepts. Martha Olson from Iowa Lakes Community College. This is part 2 of the Fluid and Electrolyte IV unit. We will discuss active transport, diffusion, osmosis, and filtration. Active transport requires energy. It's moving electrolytes across the cell membrane against a concentrated gradient. Example is the sodium-potassium pump. We see our major intracellular electrolytes are potassium, magnesium, and phosphorus, and our extracellular are sodium, chloride, and bicarb. Diffusion is passive movement. Solutes move from an area of greater concentration to an area of lower concentration, similar to when you put cream in coffee, and if you don't stir it up, it's all going to stay kind of in one area, and so when you diffuse it, you are able to stir it and get it evenly distributed. Osmosis is the movement of water across that semi-permeable membrane. Remember, osmosis is only water. It goes from an area of lower concentration to an area of greater concentration. Similar to when you boil a hot dog, it takes water in, and if you boil a hot dog too long, that semi-permeable membrane or skin of the hot dog will actually explode. Water crosses very easily. Particles are not permeable and do not cross well for osmosis. Filtration is fluid moving out of capillaries and venules and back into the fluid to move them back to the heart. As we think about filtration, I think of a coffee filter works very much the similar way. The large coffee grounds are left in the filter. The water seeps through, making a great drink called coffee. Our alkaloid osmotic pressure then has to do with albumin. Albumin, remember, is a fairly large protein. Blood is where albumin is contained along with other proteins, and those are called colloids. Proteins stay in the blood because they're too large to filter out into the cells and they can't dissolve. So as you can see, we have the cell, we have the interstitial space where there's fluid and edema, and then the albumin stays in the blood. Albumin, because of its large size and its pull, it pulls fluid from that interstitial space to capillaries. When you see somebody with a lot of edema, you need to look at their albumin level to see if that's low, because if they don't have enough protein albumin in the blood vessel, that fluid then will be able to easily seep into that interstitial space, causing edema. Albumin is made in the liver, so as you're processing all of this, think about the patient that has liver failure, cirrhosis of the liver. Any of the liver diseases can possibly have low albumin, and what we typically see with liver failure is not only a lot of generalized edema to the body all over, but we also see what we call ascites, which is abdominal fluid, where they actually can look pregnant because they have so much abdominal fluid. In the diet, albumin comes from our meat sources and other protein-rich foods, and your normal albumin level is 3.5 to 5.1. Patients that we might see this being important for is your congestive heart failure and your patient with inflammation. As we think about that large albumin being able to leak during inflammation, when you have inflammation, the capillaries are opened up, and the albumin then is able to leak into that interstitial fluid. We also see with heart failure, the pump is ineffective, and that increased capillary hydrostatic pressure can help promote or cause edema. We see fluid and sodium restricted diets, oftentimes for your patient with congestive heart failure, because the sodium pulls the fluid with it, and if we don't have the sodium, we won't see as much retaining of fluid. Osmotic pressure is fluid in the compartment that exerts that osmotic pressure. In the cell, it's that inward pull from the particles in the fluid. Remember, it pulls water into the cell. For interstitial fluid, it tends to pull water out of the cell and into that interstitial space. So as we look at that semi-permeable membrane, our osmotic pressure is not even, and we need to help equalize that. Normal body fluids, the person typically takes in about the same amount that they eliminate on a daily basis. We get food from water, especially foods like lettuce, watermelon. Many of your fruits have a lot of water content in them. And then we get water from food oxidation. So a typical intake is about 2,000, 3,000 milliliters a day, depending on the person. We also lose about that much, most of it in the urine, but we also lose fluid through the skin, through sweat, through the lungs. If you go outside on a cold day and you breathe out, you see your breath. That is the evaporation of the fluid from your lungs. And then also through the feces. Your GI system loses about 100 to 200, depending on if they have diarrhea and loose stools or not. Our balance in 24 hours should be about equal. Many patients in the hospital or your clients need to have an intake and output. You do not have to have an order to start a patient on intake and output, but if you do intake and output, be very accurate, be very strict with that, because otherwise it's not worth doing. As we look at urine output, remember that milliliters per hour minimum of 30 for an adult. Now that will be very different based on pediatric patients, so we just remember 30 mils an hour is the minimum urine output for an adult. And those not on your hourly outputs, usually we look at 8 or 12-hour shifts to measure the amount of output that they have had in that time period. As the registered nurse, then, we're going to be assessing the patient to see what factors they have that are influencing their fluid and electrolyte balance. Our nursing history, how long have you had diarrhea? Can you describe what a loose stool is? Because watery and loose might be different for them. We do a complete head-to-toe physical assessment, and then we also need to be looking at the diagnostic tests that the physician orders and reporting abnormals and looking for the ones that we think are important. And if the physician did not order them, we might prompt or discuss that with them as to, I wonder what the albumin level is. I notice there's a lot of edema. Fluid balance is also affected by things like confusion, an older adult that forgets to eat or drink. Patients that have depression may go for periods of time where they do not drink. Many of the meds for depression or other mental health disorders oftentimes cause people to feel thirsty, and sometimes we almost have to limit them with the amount of water they're drinking. They feel thirsty and they overdrink. The aging process, patients that are taking a diuretic to help get rid of fluid, your patient with congestive heart failure that takes 40 milligrams of Lasix every day. And then any physical disorders, if they are paralyzed and they can't get up to get a drink, or if they have arthritis and they can't get the refrigerator door open, any of those types of things might impact the fluid balance that we have. We know the body has organs that are very much influenced by fluid balance, the cardiac with the perfusion, the renal or kidneys with the elimination, and then the respiratory trying to get oxygen in to maintain that oxygenation balance. As we look at subjective versus objective data, subjective is what the patient says. They may tell you they feel dizzy when I stand, my heart is running away or beating in my chest very hard, or palpitations. Ask them about their usual intake. They can tell you, I always drink a big glass of water when I wake up in the morning. Any changes they've noticed to the skin. Maybe they'll complain that their lips are very dry. And then what are their elimination habits? Do they typically have, normal elimination patterns, or is it very different right now? When we do our complete head-to-toe assessment, we want to be looking at things like their heart and lungs are very important. And as we look at Maslow, we know that airway is number one. And so what do the lungs sound like? Do they have a lot of fluid and crackles in the lungs? Skin turgor is not the best indicator for fluid assessment, because older adults with the changing of the fibers to the epidermis, we oftentimes see that they will tent even though they're very well hydrated. Mucous membranes might help us a little bit. Blood pressure is a very good indicator of hydration status, as is daily weights, but we have to kind of look at the other things that can impact those assessments. If weight is obtained, which can be a nursing order, make sure it's the same scale, same time of day, with the same clothes or same things on the bed. Medications that affect, like we talked about, the diuretics have an important impact on fluid intake and output. Environment, how humid, how dry is it? If you live down in Las Vegas where it's very dry in the desert, you're going to require more fluids just to stay hydrated, as well as people that live up in the mountains, Albuquerque, Denver. High altitudes can impact that. Diet and lifestyle, are you used to drinking water throughout the day, or is that something that maybe you drink more coffee and pop, which are natural diuretics? And then their past medical history. We look at the impact of surgery on fluids, and we know that there are many things that can impact that. Blood loss or EBL during surgery, nausea and vomiting, stress. Some of our risk factors as we look at some of our high-risk groups are vomiting and diarrhea, chronic illnesses, meds they're taking. Do they have the food budget to buy food, healthy food, proteins, and then look at their skin. Older adults with very thin, fragile skin that are dehydrated, perhaps are on steroids that are very hard on the skin, they're on diuretics that keep them very dry, can have many skin issues, skin breakdown as a result of their other health conditions going on. As we look at weight, make sure that you're able to calculate how much a person would gain or lose based on their fluid. When the urine output is low, their weight goes up and we see fluid volume retention. When we have low urine output and low weight, we see a fluid volume deficit or a dehydration. Daily weight and blood pressure are better indicators of fluid balance than skin turgor because of changes to the skin, especially that older adult. Starting to look then at dehydration, we see that the patient is going to have many changes physically. Their blood pressure is low. The confusion can come from several things, but most of it is the lack of fluid to the brain, past the blood-brain barrier to keep them. It can also be a lack of perfusion to keep the oxygen to the cells. They can become lethargic or very tired, very weak. They don't want to do anything when they're dehydrated. And it's usually caused from either inadequate intake, and we see that a lot of times in the fall with the kids that are starting to run and work out really hard for football practice and cross country. They're just not taking in enough adequate fluids to replace what they are losing through sweat and urine. And then excessive output, taking diuretics, other medications that can cause more output. So there are a lot of reasons. I've seen children come into the hospital where they're very limp, very lethargic, just like a little rag doll when their parents bring them in because they've gotten dehydrated very quickly. In children and older adults, that dehydration sets in very quickly, and for kids it's because about 90% of their body is water. And so it's very important that we teach and educate families and young parents about, looking for, 3 diarrhea stools. What does that child look like? Are they having urine output? Is the soft spot on the head decreased or caved in because of the dehydration? As we look at dehydration, lots of reasons. The vomiting and diarrhea, we think of being home with the flu for a couple of days, can cause some of that. It can also be from a very wound that's draining a lot, or a hemorrhage. A patient goes to surgery and you have a large hemorrhage or blood loss during that time. A patient with a temperature is also going to need more fluids because they are losing a lot of their fluids through the sweating process with that fever. Our signs and symptoms then of a fluid volume deficit, they will be very dizzy when they stand up. And if a patient complains of that, or you notice they're a little wobbly when they stand up, do the ortho blood pressures, the lying, the sitting, and the standing, both blood pressure and pulse, to assess if that blood pressure does drop more than 10 to 20 millimeters of mercury when they go from one position change to the next. We want to record the findings, and you do not have to have a physician's order to get ortho blood pressures. Working in the clinic, it was just an understood thing that I would get ortho blood pressures on patients that it was indicated. Anybody coming in with dizziness, inner ear, fluid volume deficit, the physician just expected that I would have that completed and on the chart when he came in the room, because it helped him to assess how critically ill this patient was and the level of dehydration they had. So when we look at orthostatic hypotension with fluid volume deficit, we know that a person that goes from one position change to another, their vessels will change to compensate. The person that's not tolerating it will not compensate, and you will see that dizziness that results.